Hello from the Centre for the Studies of Asphyxia and Resuscitation, CSER. Today we would like to share a recently published article in Pediatric Research comparing two chest compression techniques during pediatric CPR, thanks to the Women and Children's Health Research Institute and the Stollery Children's Hospital Foundation at the University of Alberta for funding the study. Please note that the chest compression technique described in this study was developed in the Schmalzer and Chung lab. The current recommended practice for CPR in pediatric patients with an advanced airway is to deliver continuous chest compressions with asynchronous ventilation. That's called CCaV. We developed an alternative chest compression technique for neonatal CPR, which may also be beneficial in pediatric patients. What is different about this technique? Well, our technique combines continuous chest compressions with a high distending pressure or sustained inflation, and this is called CCSI. What is the difference between the two? On the left, you see CCaV. This is generally done using a self-inflating bag without a PEEP valve. During continuous chest compressions, ventilations are delivered not synchronized or asynchronized, with chest compressions by squeezing the self-inflating bag. When you check the respiratory function graph below the movie, you will see the spikes indicated by black arrows, which are the inflations. Between each of these inflations, you still see some smaller spikes, which will move air in and out of the chest. Now, with CCSI, we use a T-piece with a set PEEP and PIP, and we would provide this high distending pressure, or SI, for 30 seconds, followed by a 1 second pause and then again a 30 seconds of SI. When you check the respiratory function graph below the movie, you'll see the spikes indicated by black arrows, which are the inflations. Now during CCSI, each chest compression is also a ventilation as air gets forced out with the chest compressions, and during chest recoil, air passively flows back into the lung. This study compared the rate of achieving return of spontaneous circulation, or ROSC, between CCSI and CCaV during pediatric CPR, and this was investigated using our Piglet model of asphyxia-induced cardiac arrest. What did the study find? CCSI resulted in an improved rate of ROSC and a shorter duration of resuscitation. Just check the Kaplan-Meier survival curve. Why do we think CCSI improved survival and duration of resuscitation? We think that there are two mechanisms which contribute to this. First, piglets resuscitated with CCSI had improved systolic and diastolic blood pressure during CPR. Why is that? Have you heard of the thoracic pump theory? During chest compression, antegrade blood flow is achieved by direct compression of the heart between the sternum and vertebrae, thereby ejecting blood. This is called cardiac pump theory. And by increasing intrathoracic pressure, which is achieved by continuous chest compressions, this is called thoracic pump theory. While we used continuous chest compression in both groups, in the CCSI group we also used sustained inflations, which further increase intrathoracic pressure. So with CCSI, we have two interventions which increase intrathoracic pressure, which we believe contributed to the improved outcomes. Second, each chest compression forces air out of the lung. So you need a maneuver to recruit the lung continuously to improve oxygenation. During CCaV, chest compression and ventilation are not synchronized and results in loss in tidal volume and atelectasis. Check the figure above. We found a loss of up to 6 mL per 7 chest compressions despite inflation, so more comes out than goes in the lung. Now, if you do 100 chest compressions and you lose 6 mL per 7 chest compressions, you might lose up to 85 mL per minute. Doesn't seem much? Well, if you are a 10 kilogram child with a total lung capacity of approximately 500 mL and you lose 85 mL per minute, you might get atelectasis and delayed ROSC. Now, with CCSI, we do not lose any volume, we gain a minimal volume of approximately 1 ml per chest compression, which would be approximately 100 mL per minute. These two mechanisms improved hemodynamics and better lung aeration, and are therefore improved outcome. In conclusion, our study reported improved survival following pediatric CPR with CCSI compared to CCaV, as well as a reduction in the need for ongoing resuscitation over time. Now we have done 3 studies so far, just check them above, and all show the same. Do you think it's time to try this approach in a clinical trial in infants? Let us know what you think. Thank you. Please follow us on Twitter or YouTube or visit our website for more.